Good afternoon, everyone. Welcome to the Dementia Asia Living with Dementia series. My name is Etienne, and I'll be your MC for today. Thank you very much for taking the time to join us online. Today's webinar is organized by the Yeo Boon Kim Mind Science Centre and generously supported by Emeritus Professor Hong Hai and Ren Hai Clinic. Towards the end of the webinar, we will also be conducting a Q&A session with the speakers. Kindly submit your questions using the Q&A button located below of your screen. Please note that the webinar will be recorded and posted on our YouTube channel. I would now like to pass the time to Emeritus Professor Kwa Ee Hyok. Prof. Kwa, please.
Thank you very much, Etienne. It is a beautiful afternoon here in Singapore. There are about 2,000 people viewing this webinar. And some friends in Australia texted me this morning and told me that it's sizzling hot in Australia. But other people up in the north, as far as China, were viewing it, told me that it's freezing up in China. In Singapore, the weather is just nice, very cool this morning. We are very glad that you all joined us today for this webinar. And as Etienne mentioned, it's been sponsored by Emeritus Professor Hong Hai, the former Dean of the Business School at the Nanyang Technological University. And in the past, in this series, people have always asked, how do we take care of our elderly parents with dementia? So in this particular webinar, we have Professor Mahindran to talk about management, diagnosis management, and 3 other people who have looked after parents with dementia. So the first speaker is Professor Rati Mahindran. She was formerly the medical director or called the Chairman Medical Board, has many years of experience on caring for people with dementia. So should we welcome Professor Rati Mahindran.
Thank you, Prof. Kwa. Can everyone hear me? Yeah, so good afternoon, everyone. It's good to be here to talk to you all about assessments and investigations for older adults with memory complaints. So what usually happens as we age is we begin to worry, and mainly it's about memory. And then when you start worrying about your memory, I think the thought goes on to, is this dementia? Is this what's happening to me? So actually, there are many reasons why our memory can sort of decline or over the years as we age. I mean, one of the things is it's just normal aging. It could be a mild cognitive impairment, yes. It could be dementia, but it could also be a lot of treatable conditions. So the important thing, rather than worrying about it, is to really go for an assessment. Next slide, please. So the assessment with the doctor usually is very important because the doctor will attend to that complaint of memory difficulties, ask about the onset, the duration, the progression of the symptoms. If it is something that has come on very acutely, obviously there's a great deal of concern whether there could be a infective cause, particularly if there's associated confusion that might herald actually a delirium, and that needs urgent treatment. But by and large, they will not only ask about the memory complaints, they will ask about other cognitive impairments as well, or deficits. So things like, how is orientation been? What about the use of language? Have there been problems? Have there been difficulties with attention, difficulties with making decisions, for example? So there are several things that will be asked and to help with the diagnosis. Now, the other important area also that doctors will ask about is about life events in the older person's life. So has there been recent stressors? It could be in the form of having had to move house. It could be a loss of a family member or a close friend. So all these things too can impact the memory. The next slide, please. Functional assessment is important because it helps to understand how cognitive symptoms affect everyday life. So sometimes an objective record may be done by the doctor. They may use questionnaires, Bartels, ADLs, which assesses basic activities of dressing, feeding, toileting, and so on. Or they may use another one, which is called the Lawton's instrumental activities of daily living, which actually looks out for higher functioning matters, things like the person's ability to manage finances, to manage their own medications, to travel independently. I think what's important here is that changes over time and loss of independence actually signal more advanced cognitive impairment, and functional change best predicts disease progression. Next slide. So the medical and psychiatric history is also important. And here the doctor will ask about chronic diseases, hypertension, diabetes, and other illnesses, cardiovascular issues, pulmonary disorders, ask about the presence of a stroke or history of a stroke, Parkinson's disease. And psychiatric history is also important because we do know that depression, anxiety, or past psychotic illness can play a role with memory changes. Now, depression in older adults in particular can closely mimic dementia. In fact, there's a term for this, pseudo-dementia. But the important thing, if it is recognized early, it is treatable. Depression and anxiety commonly coexist with cognitive impairment and may be both cause and consequence. Now, alcohol use, substance use, again, another area that the doctor will inquire about, because chronic alcohol use, excessive use in the past, damages the brain cells, creates nutritional deficiencies, especially thiamine, vitamin B1. And so all this causes brain atrophy. In fact, a common presentation with some people with chronic excessive alcohol use is a syndrome known as Wernicke-Korsakoff syndrome, which affects short-term memory. It impairs judgment and also contributes to difficulties with coordination and imbalance. Family history is also important, not only for memory issues, cognitive issues, but other psychiatric problems as well. The next slide. So in terms of cognitive screening tests that can be done at the first interview, there are two that are short, brief assessments. One is the MMSE. Many of you would have heard of it. It is a modified mini mental state examination. It just consists of about 30 questions, and it covers a range of items such as orientation, immediate memory, delayed memory, language, and things like that. It is quite easy to do. It's not difficult. The MoCA is a little bit more challenging because not only does it test those cognitive domains that I mentioned earlier, but it also looks at executive functioning and visuospatial skills. So both of these can give a snapshot at that first interview. However, we do know that educational level, one's language, the background, occupational background, the person had. All these can significantly influence test performance. And so sometimes a more detailed neuropsychological testing may be needed. This is in early cases where maybe the MMSE and MoCA did not show up anything, but the doctor would probably suggest a more detailed testing. And also, when the diagnosis is a bit difficult in early cases, we need to differentiate the different types of dementia, then more detailed testing will be needed in separate sessions. Next slide. Okay, so mood and behavior assessment is important because these can accompany cognitive disorders. Right. And these symptoms can be distressing, not only for the patient, but also for caregivers, and it can significantly affect quality of life. So early recognition of these actually allows us to use non-pharmacological strategies first. But the important thing is, if these mood and behaviors have sudden and acute onset, then they may signal something more serious, like I mentioned earlier on, like a delirium or even medical illnesses. So identifying these early actually allows us to provide targeted treatment and improve outcomes. Next slide. Another area that the doctors will focus upon is, of course, assessing the risks. How safe is the individual now that there are some memory issues that have been identified? So they look out for history of falls, they identify frailty. What are the financial risks? Is the person vulnerable to financial exploitation? Is there wandering behavior and then losing one's way around? If the person is driving, is it safe to continue? Is the home setup safe for the living conditions, are they safe for the individual as well? So again, this is important information. This is important information really for caregivers, because then they can start planning, make practical plans, make arrangements for supervision, and of course, decide on support services that are needed to help their loved one. Next slide. Physical examination, important component to help identify systemic illness, and importantly, to look out for neurological signs. Is this a stroke? Is this Parkinson's related? And so on. So those are the things that will be identified and looked out for. Next slide. And this will be followed by lab investigations. So if recent lab investigations have not been done, say in the last 6 months or a year, the doctor may actually order a whole range of blood tests. And this could be basic things such as a full blood count, electrolytes, renal, liver function, and a full screen really, including some of the vitamins, folates, and other elements may be included in the blood test. However, if things have, if things are more acute, the onset of the symptoms are more acute, then of course, there may be additional tests that are warranted. Okay, so the investigations help rule out metabolic, nutritional, or systemic causes of memory problems and guide appropriate treatment. Next slide. So now we come to the brain imaging. Usually at the first visit, doctors would suggest doing some brain scans. So there are different types of brain scans available. I put some pictures there. There is the CT scan, which is really often used by psychiatrists as an initial screening tool to exclude conditions such as stroke or tumors or clots. The MRI, however, offers greater detail, higher resolution images of the brain, particularly for vascular changes and patterns of brain atrophy. And so in very selected cases, PET scans may be ordered. And that one helps to assess brain metabolism or amyloid deposition, and also helps differentiate between different types of dementia. So I've highlighted on the slide really some of the important findings one would see, for example, in Alzheimer's disease. There may be hippocampal atrophy, the area where memory plays an important role. When there is frontotemporal dementia, for example, the atrophy would be in the frontal and temporal regions of the brain. And in vascular dementia, where hypertension, diabetes, and medical conditions like that have contributed to the cognitive deficits, one may see infarcts and white matter changes. Okay, so next slide. Okay, so now coming very quickly to how management will proceed. It's always multidisciplinary, yet individualized to the patient's needs. So very often, case managers or care coordinators may come in. Referrals may be made to other specialists if there are areas that consultation is needed on. So psychoeducation about the diagnosis, the findings, how to move forward, what treatments are to be offered, all that will be discussed. Lifestyle modification where it's needed. If cognitive stimulation is needed, then that will be also discussed. Attention will be paid to the management of medical comorbidity. So is the patient's cholesterol levels, for example, well managed? Are the patients taking their medication regularly or omitting, forgetting to take medication? Talk about pharmacological treatment when it comes to dementias, what is available. And advanced care planning, attention will definitely be given for that as well. So it's important, of course, to engage the caregivers, and caregivers who do come at the very start from the first interview. You find that they really help the patients in managing the journey. Regular follow-up is important, and linkage to community services is also important. Okay, so now coming to the next slide, just 2 slides to talk about where to seek help for memory problems in Singapore. I think one of the profs is going to touch on this as well, but I'll quickly run through this. First point of contact, right? A good place would be the polyclinic or family physician who knows the patient well. So discuss memory concerns early, basic medical review, blood tests can be done. And if the doctor at that point feels further assessment is needed, then they would arrange the referral as needed. Step 2, specialist assessment. I know some people may skip step 1 and go directly to arrange for an appointment in memory clinics that are available in many of our restructured hospitals, or they may also go to specialist outpatient clinics in the private sector, and they may arrange to see a geriatrician, a neurologist, or a psychiatrist. Any of these can do these assessments for you. Geriatricians tend to manage the older, also probably those who are above 70, 75, and so, whereas the neurologists and the psychiatrists will be able to see those in their 60s and 70s without any issue. So here again, detailed cognitive and functional assessment will be done, brain imaging and specialist tests, and of course, diagnosis made, care planning worked on. And so this is available in public hospitals and private centers. Next slide, please. And this last slide on the where to go for help. The third step really is for ongoing care and support. So now if the diagnosis of a dementia has been made, where do you go from there? So there are a lot of services available in Singapore. They can be community as well as hospital-based services. Dementia daycare centers are available. Allied health services, some are available in the polyclinics as well, can get access to physio and occupational therapists. Medication review and follow-up becomes important, and this can be coordinated through the hospitals and through the Agency for Integrated Care, or AIC. In step 4, there are other additional services out there, and I'm sure our caregivers will be able to tell us more about some of these, but briefly, Alzheimer's Disease Association, for example, education, counseling, and daycare, they provide that. Dementia Singapore provides caregiver training and support groups, and AIC helps with care navigation, subsidies, and respite services. And finally, of course, an important step is to start planning future care and advanced care planning. Okay, so there are a lot of discussions about advanced care planning, financial and legal planning, and progressive care needs and safety planning as well. LPA, will, all those things need to be thought of once the diagnosis is clear. All right, so I will just go on. So I've got some snapshots. I hope I have some time. I will just cover some clinical types of dementia, the presentation, just to show that there are differences. And that's why that history taking and the examination that is done is important to help us with the diagnosis. So the first case is of Alzheimer's disease. And this is a 74-year-old lady who presents with a 3-year history of gradually worsening short-term memory. She repeatedly misplaces items, asks the same questions, and struggles to recall recent conversations. And over time, she develops difficulty managing finances and navigating familiar places. Her personality remains largely unchanged in the early stages. So here the important thing is that insidious onset with steady progressive decline, early impairment in episodic memory is characteristic. Functional decline follows cognitive deterioration. The next slide. Lewy body disease. This is a vignette of a 76-year-old man who was brought by his spouse for fluctuating cognition over a year. On some days, he's alert and conversational, while on other days he appears confused and inattentive. He reports seeing people in the house where there is no one, so hallucinations. Examination reveals mild Parkinsonian features, including bradykinesia or slowing down, and rigidity. Points to note from this little story is that cognitive fluctuations and visual hallucinations are core features. Parkinsonism may be subtle early on, but as the illness progresses, it becomes clearer. And unfortunately, these patients although they may need antipsychotic medications if the psychotic symptoms worsen, they tend to be highly sensitive. So there is some need to be regularly and carefully monitored, and the use of these medications reviewed regularly. Next slide. Frontotemporal dementia is another form of dementia, and this can take two forms. Firstly, the personality and behavioral change can occur. So this is a 62-year-old man who was referred for marked personality and behavioral change over 2 years. He has become socially disinhibited, emotionally blunt, and impulsive, with poor judgment at work. So that's quite typical of a frontotemporal dementia, that history. But there is also another presentation that some patients can come with. It's not so much the personality and behavioral changes as the language that is affected. So here, a person may have progressive difficulty finding words and understanding language despite relatively preserved memory in the early stages. So here for frontotemporal dementia, the onset is often earlier compared to Alzheimer's disease. Behavioral or language changes predominate over memory loss. And sometimes because of this presentation, the behavioral changes, it may be seen or diagnosed as a psychiatric disorder. And the cognitive part, because in the initial stages it's quite intact, that issue may be overlooked. Next slide. And this is my last slide, really. A 78-year-old lady with long-standing hypertension and diabetes develops cognitive decline following several minor strokes. Her family notes a stepwise deterioration with periods of stability between these sudden declines in the cognition. She has prominent executive dysfunction, slowed thinking, and gait instability alongside focal neurological signs. So the important points in vascular dementia are these: the picture of a stepwise progression that suggests vascular pathology. Executive dysfunction often exceeds memory impairment, and aggressive management of vascular risk factors actually is essential if we are going to manage a person with vascular dementia. Okay, so I will end there. Thank you very much for your attention. And Prof. Kwa, over to you.
Thank you very much, Professor Mahindran. She has given a very succinct description of diagnosis and also the management of dementia. Some years ago, we wrote a book on caring for the elderly. Who cares? It's not in a cynical way we ask who cares, but who are the people who really care for people with dementia? And the first speaker is Professor Tan Leng Leng. She is the president of the Gerontological Society of Singapore and also the chief of the Japanese Studies Department in NUS. Leng Leng has looked after aging parent and dementia, and she's going to share experience and her perspective on what more can we do. So we welcome Professor Tan Leng Leng.
Okay, thank you. Did you? Yeah. Okay. All right. Thank you very much, Prof. Kwa. Can you hear me? Okay. Yeah, so I will be sharing about the journey of dementia care when my father had dementia. So, okay, second slide, please. So just just a very short introduction that I do research on aging in Japan and in Singapore as well. And I started the research interest on active aging, but over time I came to learn more about challenges of aging, especially faced by caregivers. So and I've done some research looking at caregivers, including those caring for dementia elders. But of course, nothing beats becoming a caregiver myself when my father started to have dementia. Next slide. I also write in Chinese and I have a column in Taobao. So the Taobao essays actually became an avenue of my reflection as a caregiver. In these articles, these are the 3 articles that are directly related to my role as a caregiver. I just like to introduce briefly here an article that I titled A Dance, A Journey, 一支舞,一趟旅行. So the title is taken from Terry Cargrave, who is known as a founder of restoration therapy. And he has written about this, as a dance, a journey in caregiving in his book, Loving Your Parents. So just basically here I put on the slides about how he looks at his reminds us that caregivers and the elders are not trapped in a battlefield of hostility. We are dancing a dance that requires close communication, humble compromise, and encouragement, encourages trust throughout. So it's important that we don't need to dance perfectly because caregiving, the whole connection with the carer, the care recipient, it's also a form of learning that doesn't have to be perfect, but we just need to keep moving. Okay, so just small sharing on that. So next slide. So Prof. Kwa say, okay, these are your questions as a caregiver. So what I'll do is I think it'll be best that I kind of go through the questions, responses from it. So that's my father on the right when he was alive. He passed away 2 years ago, and today is actually his second death anniversary. So, how do I know that my father has dementia? So, I think Professor Mahindran talks about the background is important. So maybe let me just start with a little bit of background from my father. He was an accountant, quite an active person, and he knew that it was important to have regular exercises. So he exercised on the treadmill at home regularly. He kept a social circle after he slowed down from work. So he used to have regular drinking sessions with his friends at the club. He had sometimes makan sessions with his primary school classmates. So he slowed down from work after 70s, but still, getting working some sort like a part-time consultant for the company. So he would always say that, he wants to retire fully, but I believe it was important for him to hold on to the job identity. He didn't have to go to office much, but once when he was at office, he had a fall and he was sent to a nearby hospital. So the fall was an alarm to the beginning of his frailty. I think that's probably when he was late 70s or early 80s. He was still cognitively quite okay. He was showing signs of forgetfulness, but I'm sure it wasn't dementia. It wasn't like a behavior of dementia until October 2020. So that was the year where 2020 was the year that COVID started. So he spent the whole time at home with my mom. The both of them live on their own, but very close to me. So I could clearly sense that he became different from October. When he had his fall, he was sent to Raffles Hospital and then he saw a geriatrician, which he continued to go to every few months after that. So it was good that we have a GP or a specialist that he would always go to that's familiar with him. So and in December when we went to see the geriatrician, I told her about my concerns. True enough, he was diagnosed with dementia during the visit, and it was I think it was vascular dementia because he has been having high blood pressure and diabetes for a long time. So I would guess that I know of friends who got very, lost when they hear that their loved ones have dementia, but I think it was my knowledge in dementia that helped me to detect that he's not right, that that he's not just being forgetful, but somehow showing a sense of loss and hesitation. And he also started to lose ability to do what he was used to, such as taking care of his own medication. He also fell down quite frequently during the period, especially when he was trying to get up from bed. So it was only in like February or March the following year that I realized that why he changed in October, why there was this change in October, because the company staff told me that, oh, actually your father stopped employment, stopped full employment. That means stop being employed since the end of September. And he didn't tell us that at all. So I guess it was that loss of work identity that might have been also a cause of triggering his dementia. And of course, COVID too could be a culprit as well. But he was already 85, 84 years old then, and it's not, that unusual for people his age to be getting dementia as well. So although I research about caregivers of dementia individuals, but in fact, I did not really have a lot of chance to meet with persons with dementia. I knew a few from church who could still walk, although with dementia, but it was the first time with my dad that I experienced the whole process of someone becoming dementia and the development after that. So in a way, I was glad that he became frail, like, he had started to have difficulty in walking, becoming frail before he had dementia, because it would be really tough to think that, he would be walking all over and getting lost if he's still mobile. I knew that his experience, his behavior could be quite unpredictable. Sometimes he would scream and spoke vulgarities, very, very unlike who he is. But on the other hand, also, although a person diagnosed with dementia, he also has lucid moments, which I chose to focus on such time when he was lucid, and we would enjoy really hearing him being, his own humorous self and sometimes speaking some words of wisdom. So where did I go for diagnosis and treatment, family support, and community care? The second question. So well, we were able to go to the same geriatrician that see him through the years after that. So I have a younger brother and a younger sister, so I'm the eldest in the family of 3 siblings. And my parents had moved to live very close to me. As I said before, it was around 2 minutes of walk. So to me, that was the best decision they had made, because it really makes it so much easier for them to get care quickly, because I'm just next to them. My family is just next to them. So actually, after he was diagnosed with dementia, my mom wanted to put my dad in a nursing home, mainly because she saw that was what her friends did with their husbands. So it was, of course, obviously impossible for her to be taking care of my father at home on her own. My mom was also 80 years old by then. But the siblings were against it. We felt that, it's still the best for dad to be staying at home. So family tension can be quite a challenge during these times. But so in the end, we say, why we should ask dad. We are making decisions without asking him. So we should ask dad what he wants. What is it we should ask his view of where he wants to stay. So we asked him, and he said he wanted to stay at home. So with that, we went on to our next step of, getting a helper. That's very common in Singapore families. If you want to have care at home, quite commonly we will engage a foreign domestic helper. At that time, my dad had already started to stay awake at night. So we have to first get someone to work in the day, and then to also look for someone to take the night shift. So we need to go for 2 helpers. So it was actually a big challenge to employ a helper during COVID period. it's quite difficult. But fortunately, we got the daytime helper quite soon, and then I gave myself a month to search for someone who could take the night shift. That means this person would sleep in the day and then stay awake in the night with him. So while we are looking for the night helper, we engage the services of some companies that provide caregivers on hourly basis. So this person came from 11 p.m. to about 6 or 7 a.m. the next day. So we had somebody who come in every night for a month, and it costs around 7,000 Singapore dollars. Luckily, I only need to do this for a month because we found someone, a Myanmar helper, with some years of experience caring for bedridden individuals at home by the end of the month. And she was really good. She could speak good Mandarin and very patient and knowledgeable. She stayed for 2 years, went home to get married, and then we had to find another person, which we were fortunate that it was a very good and well-trained person as well. So, but my dad passed away 2 months after the new helpers came in. So, although we did have a good experience with the night helper, my mom was quite picky on the day helper because it's the helper that she would get to see, right? So, to interact more. So there was quite a bit of conflict and tension that, frankly, it was frustrating for me because it's like I'm already doing with, and then these are like additional tensions that I have to manage. We changed 3 helpers in a few months until I had to tell my mom, she may be blacklisted if she keeps doing, and I can understand it's very difficult for her because she's so used to be, taking care of the whole thing in control, and she felt that it was difficult to find someone that she accepts, she thinks is good enough. So in retrospect, I realized it's easy for adult children to tend to focus only on the patient with dementia and then the parent with dementia, and then we forgot about the spousal caregiver, the aging spousal caregiver also need to be supported. And increasingly, so more of we are going to get more of husband and wife, and one had to take care of the other with support of the adult children with longevity nowadays. Okay, on engagement of community care. So the doctor also suggested that my father should go for rehab in a nearby senior care center. So we were linked up by AIC, the Agency of Integrated Care, that will help us to find and locate the nearest center. So we live in Serangoon area in Singapore. So the nearest is Kwang Wai Siu Senior Care actually. And AIC was very prompt in contacting me that, okay, this is a place you should go because we could, it's a walking distance. But they say the waiting list is long. It may take up to a year before he can get a place for rehab. So that was disappointing because imagine you have to wait for a year for rehab. So, how much would my father had lost, in that opportunity over that time. And so I feel that instead of just saying that, sorry, you need to wait for a year, it would be great if, despite the lack of a place, the care center could still be recommended to, to make an appointment with us so that we can know what can we do in the meanwhile, what other kind of services can we engage in while waiting for the rehab places. And also what kind of resources we can get in the community. Although there are always, resources that you can see online from different like Dementia Singapore and so forth. But I think it would be good if it's someone that's near you that that you would have more connections with during the period afterwards. So fortunately, the Kwang Wai Siu called us in less than a year. It was quite fast, and he was placed for twice a week for a 1-hour rehab session. But after a few months, when he had to be hospitalized, then he didn't go back to rehab again because the center could no longer have slots for afternoon and so forth. So he stopped attending. So it was a pity, and it also caused me to realize, sometimes there could be mismatch in services and so forth. Another experience is when at first I was thinking of, whether there's any respite care at night that we could go to, because I think as part of what's offered for helping caregivers, there's this mention of respite care in the nursing homes. And of course, it was turned out to be very difficult because all the nursing homes that I called to that say that they don't offer that kind of services. Okay, so how do you take care of yourself? I don't think I thought much about taking care of myself at all in that situation. But I must say that my siblings were good support. You know, we work together as a team. And it's very important to see that during these times you have your family coming together as a team. And that's including my children, my husband, and my own helper as well. Because it really takes a village to care for an older person at home. And I also thank my friends. You know, many of the caregivers whom I have met through my research, some of them became my good friends and they gave me really very good support and close support. So, you know, I look to them on all kinds of advice, like what kind of diapers are good, what kind of ointment is good for the skin, where do you buy a wheelchair, and so forth. And they are really being the experienced caregiver, they were really warm in supporting me during those difficult times. I have to thank them, and some of them may be listening in. So what future you could hope should be available for family caregiver? I really think that, you know, it can be a very isolating experience for a caregiver, and suddenly, you know, you have to care for someone who has connection problems, and you look around and you have to start wondering who are the, you know, services near me that I can get help with. So I think really knowing how to develop this closely needed network that support caregivers in community, comprising of care centers, care managers, if there are, families, neighbors, and so on, are important. So let me refer to the next slide on some of the insights from my knowledge on aging care in Japan. So in Japan, there's been Japan now adopts the community-based integrated care system. So they do have endeavor to have daycare services, group homes, those small size multifunctional home and community-based care within close proximity. And I thought this small size multifunctional, it's a mouthful, small size multifunctional home and community-based care in short term is in Japanese called shotaki. It's actually quite interesting model, especially useful for, I think, this closely knitted community care. So some of them they are long-term care facilities. Some of them are open. I don't think all open 24 hours, but some of them do open 24 hours for 365 days a year. They provide daycare services. They also provide home visit from that destination. And let me just move on to the next one to let you see some of the examples. So this is the one that I visit where it's a new one. So it's in a very aging community. They, you know, in Japan now there are many empty houses, right? So this is one of those empty houses, Akiya, that they turn around to become a long shodaki. So the first floor of it, as you see here, is like a day center where residents come in as day center services, where they have art and craft, they have lunch here and so forth. And then for some residents who need care, they would be they could go upstairs, that they can use that to help them to get up. And then they can be staying in that short stay or respite care for a few days there. Okay, so this is one of those places that I've seen around in different parts of Japan. Okay, the next one would be this is very much like our, you know, HDB flats, right? The apartments living. One of the unit is made into such shotaki so that there could be also involved like a nurse station where residents can come and get services or home care, home help from this unit. So it's interesting that the proximity is there, and also the familiarity with the neighborhood that people can go to. yeah, so I know that my time is out. So thank you so much for letting me share. Thank you.
Thank you, Professor Tang Leng Leng. It's very demanding looking after someone in a family with dementia. Certainly, need a lot of support. The next speaker is Inche Abdul Rashid bin Ibrahim. Abdul Rashid is the leader of the group in the East Coast, Tampines site, and in the dementia prevention program. And somebody who is an ardent member and have been in this field for more than 10 years. I've always wanted to explore beyond the Chinese community. What are the other groups, who are doing all this kind of work? And the Malay community is a bit different in many ways. In the research, we found that depression and suicide is higher amongst the Chinese. But among the Malay community, the depression and suicide is very, very low. And so how do they look after or care for people with dementia? So shall we welcome Mr. or Inche Abdul Rashid bin Ibrahim.
Thank you, Mr. Prof. Kwa. Hi, everyone. I'm Rashid from Tampines Jakarta, and I'm currently involved and active AWE or Age Well Everyday Volunteers. That's focus on our aging Malay community. Next slide, please. Today, I'll be covering these topics, starting with my own personal journey, taking care of my elderly mother, just like what Prof. Tang just now did also for the parents. But mine, I taking care of my mother, and starting with my journey taking care of my elderly mother. This journey had been an eye-opener for me as I took the time to fully understand what is dementia and what kind of support I can look for. Next slide, please. A bit of a background of my mother. Before her life-changing situation, my mom was a single parent, single mother raising 13 children and worked as a chambermaid, but now it is called as housekeeping. At the same time, she enjoyed baking, cooking. She has a carefree, joyful, and frequently visit relatives and families. All she needed was an address, and she could find her way independently. And the furthest she has been is to Kedah, where my sister got married to a Penang guy, where they stayed in Kedah, where my mother all of a sudden reaches there and pull a surprise to them. Okay, next slide, please. Then sometime in 2006, she had a mild stroke, which caused her to live reclusive and not being free-spirited self. She preferred to isolate in a room and not interested to socialize with everybody. Initially, I thought this was another kind of old degenerative phase, where in Malay terms, we call it nyanyok or senile. Next slide. Normally, the word nyanyok itself is a stigma among the Malays community. This was why I hid her condition from my relatives and tried to hide her from them. I did not try to get any support from family and siblings, as I was not fully aware of the assistance or other available support I can reach out to. Next slide. In understanding the dementia, so I chanced upon a talk conducted by Prof. Kwa and team on dementia prevention program around 2017, if not mistaken, at Tampines Jakarta. It was an eye-opener for me because I had to cope this alone, not knowingly there are available support in Singapore. Next slide, please. after the talk, I approached Prof. Kwa for more information on the program, upon which he then threw me a challenge to conduct a program in Malay for our Tampines community. With this support and materials, I gathered a team to start the program every weekend. That is, every Sunday we have this program conducted in Malay in Tampines Changkat CC. And till date, we are still conducting the program, and the response had been welcoming from a group from 10 to about 40 packs with 40 packs. With this, before I end the presentation, I would like to thank Prof. Kwa and team who had been very supportive and encouraging. Thank you everyone for your time. Thank you again.
Thank you very much, Encik Abdul Rashid. I want to move on quickly, and you remember what Abdul Rashid mentioned about the relationship and how they care for one another. So he has started up this group, and they use a smartphone to communicate during the pandemic, something very innovative. I want to move on to our final speaker, Professor Tan Ting Wee. He looked after not just one parent, two parents with dementia, And sometimes he'll send me an email or send me a WhatsApp message to say that he's also in the morning rowing down the Singapore River, helping to clean up the river. I will tell him, why don't you just go back home and rest? But he enjoys doing it, a sense of care for the community. So shall we welcome Professor Tan Ting Wee?
Thank you very much, Professor Kwa and colleagues, and all of you in the audience. Pathways to care for our dementia loved ones are many, and the journey arduous. And I want to share with you my personal journey in the next slide. I show this slide to demonstrate that same point which Professor Tang Ling Ling and other speakers have spoken about. Just as it takes a village to raise a child, it takes a village to look after one or more dementia loved ones. Here is a picture of a recent family gathering at a hotel. This is my village, a village of cooperative, supportive, sympathetic family members who surround with love and care for all our aging parents and grandparents. Both my parents have dementia, as Professor Kwa mentioned. Now, my mother-in-law has started to have some symptoms of dementia, and my father-in-law started to also have forgetfulness. But then in looking after my mother-in-law, he developed a heart attack and shortly after passed away. So looking after dementia parents, loved ones, has severe consequences, as my father-in-law found out. In the case of my mother and father, you can see in the wheelchair, we could not manage both at home, and we had to bite the bullet and make a conscious decision, a tough one, and send my father to nursing home, where he has been for 7 years or so. Mother is at home with a domestic helper, and my sister gave up a job to regularly turn up to look after my mom, and myself still working, and at one stage almost sole breadwinner for the whole family. In the next slide, you will see that my dad, although a retired businessman, managing director of businesses, because he retired early, he started having symptoms at age 80, starting with hearing loss and driving accidents. And at the beginning, we didn't know. And that is a problem. Being educated to understand these and recognize these symptoms is absolutely critical, because at the hearing loss stage, we could have intervened and delayed the onset of symptoms. But long story short, he started developing aggressive behavior, fighting and pushing my mother at home with fractures, and we thought he was just being aggressive. And cranky old man that I'm becoming, right? But it wasn't. It was actually his dementia acting up. And we didn't know that it was his dementia talking when he started becoming abusive publicly and abusing my mom publicly as well. And to my mom, who is a Chinese school teacher, abusive language is a complete anathema. And she was extremely upset. The other symptom he had was calling people incessantly on the phone. And then he started having memory loss, getting lost, wandering around, and then getting confused, mistaking his surroundings as somewhere else. And then he had day-night reversal, which was awful because at night when everyone wants to sleep, he's up and running. And then soon after, he could not recognize family members and gets confused with different people visiting him. And eventually he stopped reading newspapers. His sense of smell and his incontinence also developed. And now finally he is bedridden, but very well managed, I must say, because after a long journey, we managed by trial and error to find a situation where he got the appropriate vitamins, appropriate medications, as you see on the right-hand side, the columns showing that he took valproate, and the doctors at St. Luke's managed to find the correct drug and the correct dosage in order to control his situation of aggression. He will regularly fight with the nurses as well, and eventually fall and lead to fractures as well. So even at nursing home, he's also known to be aggressive. So again, the correct type of medication we arrive at, we were very fortunate. The timing of the dosage and the dosage was also important. And if you get one of these wrong, he will manifest his aggressive behavior. My mother, in the next slide, however, is of the calm and quiet type of dementia. So symptoms started immediately after my dad went into nursing care. So we guess that it is because for many years, she had been looking after my dad. And the moment my dad disappeared from home, her will to have some purpose in life disappeared. And then she started to be socially isolated, did not want to interact with people. And we didn't know, again, it was dementia acting up. She even actively refused to attend daycare, dismissing it as being juvenile. And we didn't realize that so soon after looking after my dad, dementia had started. She started with loss of cognitive and motor skills, and the decline was so sharp compared to my dad. Now, if you look at my mom, it looks as if she's more advanced stage with dementia. She's a painter. You see this painting at the back? She's a Chinese painter and with exhibitions in many occasions. But with dementia, she stopped writing, she stopped painting, she stopped reading newspapers. Her voice and speech became incoherent, and now she cannot recognize any of us. A progressive loss of memory, in a certain sense, was a grateful respite for us, because in her normal self, she will always remember all the old things and the bad things that happened. And now with the loss of memory, she lives a fairly happy life, I would say, because all her bad memories have been forgotten. But one distressing thing was her hallucinations. But now, thankfully, she's much better. She's still able to walk, and she is currently attending St. Luke's Senior Daycare near her home in Whampoa. She hardly takes any medications because we found that her situation was, she had some allergic reactions, and none of the drugs that we tried actually, that the doctors prescribed, actually work. And then because you're sitting a lot, she developed deep vein thrombosis, and she's now on blood thinners. Next. I just want to say that how we knew he had dementia, it's just a combination of a progression of multiple symptoms adding up day by day. Of course, we brought them to see the doctors, but it wasn't an easy journey, persuading them to see the doctors. If you think you have dementia, most likely you don't. And many dementia people suffer from denial. Different people manifest different sets of symptoms, and they can come in at different times progressively. We hope for the days when occasionally they have that rare moments of lucidity. Sometimes we live for those moments when suddenly they recognize you. And those are moments when we suddenly see their original self, the self that we loved, and then the loss that we feel when they are no longer lucid. We have suffered a lot as a family, struggling with managing both parents. I just want to say to all of you out there, you are not alone. Many people have such a situation to struggle with, and the knowledge that we are not alone in itself is a tremendous blessing and a tremendous comfort. In the next slide, I want to say that and to thank all the different groups that have been helping us along the way, our family doctors, our polyclinics, geriatric specialists in all our hospital systems. Initially, the situation was pretty bad, but I just want to say that the government is doing a lot to help. And you can see the dramatic transformation. Everywhere we turn, we see senior daycare facilities, we see nursing homes, we see active aging centers, and of course, our favorite Age Well Everyday program of Mind Science Center. Not only that, many people with dementia loved ones are actually suffering from financial stress. And there are many government grants and subsidies by the Agency for Integrated Care, AIC. And you can see them now in every corner of a hospital lobby. You can see AIC somewhere. Look out for them. And they are very good at providing the necessary advice to help us access some of the subsidies, grants, or even access nursing homes. So getting educated, ideally in advance, is absolutely critical. How I regret not taking some of these courses in advance. Only after I attended the Caregivers Alliance, Caregiver to Caregiver C2C training program for dementia, that I realized that if I had attended these courses earlier, maybe some of those bad situations that we had to struggle with could have been circumvented. Now, Caregivers Alliance is called Mindful Community, and I really hope that some of us who are suffering will take some of those courses, the C2C dementia course especially. One of my staff told me, after I recommended to him, it was day and night change in his own understanding of his situation of looking after his mother-in-law with dementia. Take the opportunity to get educated, and that is my second message. Next slide. I hope that you also realize that every one of us who are giving care to our loved ones need self-care. Self-care is not selfish. It's an act of love towards yourself. Because if you are not in the frame of mind to look after yourself, and keep yourself well, you cannot look after your loved ones well. There is always a lot of guilt that, caring for myself, I don't deserve it. Primary caregivers, a lot of us suffer from the so-called martyr syndrome. But this is not sustainable because there are many cases of caregiver burnout where we actually run out of steam completely. Your cup needs to be topped up. Otherwise, you burn out. And the burnout effect is worse. And you can see to a certain degree, my mother's situation was because she probably burnt out and we didn't even know. And then she suffered dementia and in its decline herself. Even worse story would be my mother-in-law, where my father-in-law took it on himself to care for her 24/7 for 4 months. And then he developed heart attack. And long story short, he's no longer with us. More importantly also is the surrounding people, the secondary caregivers. Let's come together to support other family members who are primary caregivers, or even our domestic helpers. Let's not judge them. Let's work with them to find ways we can be better caregivers. And very often, well-meaning family members will come in with and pontificate about what you should have done and so on. Let's work together. Let's be supportive for our friends and our families with dementia loved ones, and the suffering through that caregiving process. Next slide will show you that this mountain that we are supposed to scale, this arduous journey that we are undertaking. You can't take care of anyone unless you first take care of yourself. Next slide. So what is lacking? What we need to do more in future, there are many. There are so many lacks here, I think I give up, right? It's disappointing to see that despite all the efforts, a lot of effort need to be put into dementia caregiving because it is a very serious problem. Help is underway, both in terms of social help, financial help, as well as new advances in medicine, like precision medicine, and also medication that have been authorized by the FDA. Check with your doctors. There are new surgical techniques now that are available. Check again with your doctors as to these. And some of these effects, these new treatments are now becoming more and more available. Because of all these lacking needs for all these things that I've listed on this very busy slide, I'm working very hard to create something called a Caregivers Institute, and I hope to have more good news to report to you soon. In the next slide, we finally want to say that all of us need to cope with all these difficult situations, but do care for yourself, eat well, sleep well, exercise, nurture old friendships, develop purpose in life. Even simple things like collecting rubbish on the kayaking while you're kayaking in the rivers of Singapore, like I do occasionally, or even reconnecting with old friends. These new treatments in the research pipeline, do look out for them, but beware of a lot of snake oil and fake news, right? And take part in programs like Age Well Every Day in order to age well gracefully. Finally, in the last slide, I just want to say that why do we care and how we should care for our loved ones with dementia? Sustainable care for dementia requires us to adopt a combination of a sense of filial piety, a sense of spousal love, a sense of duty, love, and devotion. Be careful of lame excuses and pushing off this responsibility for others. But most of all, you are not alone in this long journey. And finally, note that there are only 4 kinds of people in this world: those who had been caregivers, those who are currently caregivers, those who will be caregivers. You need to be prepared. And finally, like myself, aging very rapidly, those who will need caregivers in the future. And I end with this marvelous quote by the late Rosalind Carter, who is the founder of the Caregivers Institute of the US. Let's come together as a community, as a village, to support each other in this long and arduous caregiver journey for ourselves personally and for the rest of our community in Singapore and worldwide. Thank you.
Thank you, Professor Tan Ting Wee. Certainly, we must care for the caregivers. Now, there are many questions that were sent to me 2 weeks ago when the flyers went out. I want to collate them together and put them in a couple of slides to show to all of you. The first slide, please. Pathways to care. And that's the agenda that we must be able to diagnose well, must be able to manage well, must support caregivers well. And the last few days, some friends were talking to me about, what about dying well? But I think the most important is, can we prevent well to age well? Now, the diagnose well idea came up sometime in 1985, almost 40 years ago, when we were part of the World Health team for the global study of dementia. The World Health questionnaire was about 200 questions, and it cannot be used in the routine clinical work. So the chairman of that team asked me whether we could bring down to just 10 questions that we can help GPs, that can help them to screen early dementia. So we came up with a questionnaire called Elderly Cognitive Assessment Questionnaire. Now this is used by over 12 people in Asia doing their PhD, and it's used by the GPs and they can give a screening within 5 minutes whether it's a possible dementia. And in Malaysia, they use it for all Muslim people who are going to Mecca. They know that you have dementia and a hot Arabian climate, you can stir up delirium. So many of all the GPs in Malaysia, if they see an elderly person, you have used this questionnaire to help them screen. We have some colleagues of ours at the Department of Linguistics at NUS, Professor Bao Jiming and Lucian Chow. They have done an interesting study on the language spoken by people with very early or beginning of dementia. So analysis of the language itself, the spoken words itself, to give you a hint of possible dementia. And I hope eventually they came up with AI to help us to diagnose earlier and to manage earlier. Next slide. And now many people ask, most of the question is when the elderly person or the patient comes to the clinic. What happens if the patient refuses to come to the clinic and you are at home? And if the GP, if you talk to a family members, you can ask them a questionnaire which we constructed some years ago with a master's thesis by Li Ming from Beijing University, who came down to Singapore. And the question is called a brief informal screening test, informant with caregivers. The question you ask the elderly person, ask the informant is, in the past 4 weeks, does she or he has a memory problem? If there's nothing, then it's okay. If something wrong, then you ask 4 questions. When you find the personal belongings, the past 4 weeks, the loss, keep appointments, able to manage finance, can read the papers for 5 minutes. If you have 2 positive, there's a high chance the beginning of cognitive decline. I want to move on to the next one, and it's the management well. And all of our information today in Singapore and in this part of the world is derived from the memory clinic we started about 35 years ago. And we have massive data. We found that we can divide dementia in 3 phases: mild, moderate, and severe. The mild phase is about 6 years, and the moderate phase about 3 years, and severe about 3 years. So this is a very important graph because it helps the family members to know if you have someone with dementia, the doctor say you probably have mild dementia, then you know that you have about 6 years. So dementia is not a terminal illness. Dementia is a chronic illness. So the families can plan. And you see on the right side are 2 PET scans. The first PET scan on your left is someone with normal aging. The one on the right side is someone with Alzheimer's disease. And you see that even in Alzheimer's disease, there are certain areas with red areas which is normal. The brain is still working. This is very important to tell people that even someone have dementia, there are many things that we can do. It is from some of these ideas that we start off this Age Well Every Day program. And it's also from this that we know that even people with dementia, especially in the mild phase, many things we can do to help them to improve their quality of life. And you see that this patient here, the site here is called the temporal lobe. Something to do with smell and taste. It's still normal. I got a patient who came from Malaysia, from Pontian, and the son asked me, is it possible for her to eat durian? Because now the durian season. That's certainly. And she enjoys durian, she enjoys the taste, she enjoys the smell. So you see someone with dementia, and that lady has moderate to severe dementia. The smell, the sense of smell and taste is still there. Shall we move on to the next one? Caring for the caregivers. And this was something we did almost 4 years ago. When we first started a memory clinic, it's meant for people with memory problem. To the family members, if you have a memory problem, that's not a problem. It is a problem if the elderly person cannot sleep, or the elderly person have delusion that someone is taking the money, or hallucinations, then it becomes a problem. And all this, as you have heard from Professor Rati Mahendran, all these can be managed with medication and behavioral techniques. So these are things that we can do to improve the quality of life, not only of the patient, but also of the caregivers. Next one, please. And we also did a study on caregiving. So we told one group, once a week, we'll send you an email to ask you how you're getting on. And another group, you'll say, we ask our social worker to give you a ring to find out how you're coping. And so you see, we're comparing telephone counseling and e-counseling. The paper has been published, and you'll realize that although after 3 months, both groups improve, the people who are more satisfied with this, the service, are the people with telephone counseling. There's nothing like a human voice. So you see an old contraption invented by Alexander Graham Bell almost 200 years ago is still very useful to relieve the stress of caregivers. So when people talk about AI, so all of you who are helping out, who are doing counseling or psychological therapy, there will always be a job for you, because caregivers still love a human voice talking to them. But also, next one, please. You realize that caregiving is also, doesn't mean that everybody, or all of us here, will end up in nursing home. If you want to stay in your home and you grow old and have dementia, it's good first to have a family support. So in our research on Age Well Every Day, we move on to another area, frontier research on caring within the family. If you can build up bond with the family, then they'll look after. If not, they'll just leave the person in the old people's home or in the hospital and never come back again. And also to build up a group of friends in the community who will be there to help you out. So there is also a study called Where There Is No Psychiatrist, because we realize that many caregivers are under a lot of stress. If you make an appointment to see Professor Mahendran, it will take you about maybe a few months. And if you can have people in the community like Mr. Rashid or even Professor Tang Leng Leng to help them out in helping psychological first aid to help them out, that would be wonderful. And this study has just been published by Professor Shifali, who is the new director of the Mind Science Center. I want to move on to the next one, and it's dying well. Now, it's an empty space there because we don't know very much about dying well. What happened is someone at the terminal phase and is passing on, you know. Well, people tell me, well, we have advanced medical directive. Isn't it easy? No, it's not that simple. When you are at the clinics, you know, ward, and the person is going to the final phase, you have to be very careful. I know that because some years ago, there was a commotion in a ward, and a young doctor gave me a ring and asked me, can you come and help us out? And when I went up there, I realized that the daughter of this elderly lady was very unhappy because the mother had severe dementia and she had a pneumonia. And the doctor said, well, she has severe dementia and also severe pneumonia. Do we want to give antibiotic to revive her? When they spoke to the first daughter of this patient, the daughter who never lived with her said, well, never mind, she's old now, can let it go. But the second daughter who lived with the mother refused. He said, I've looked after her for the last 10 years, and you must carry on the antibiotic and revive her. So, but the young doctor said, well, she is so severe, she couldn't even recognize you. And with a commotion, eventually I told the doctor, now it's quite late in the evening. If you carry on the discussion with her, you probably cannot sleep tonight. Why not just give the antibiotic to this person? And in 5 days, the elderly woman recovered and went back home. And she went on for another 1 year. And one day I was shopping in the shopping mall, and I met this caregiver. And then she told me that it was so wonderful for me to have 1 more year with mother. And I processed the grief, they call it anticipatory grief that went through in me, and able to accept the dying mother. So we don't know very much about caring for a dying patient with dementia. So I hope that Professor Tang Leng Leng would get her team together, maybe in a social work or anthropology department, to think about somebody doing a PhD on this area, which we really don't know about. Now, in one area that we think about is important is how to prevent well. And many of you may have heard about this study, the first study in Asia, and the result is wonderful. Now, the result of the dementia of the Age Well Everyday program is derived from our clinics. That we know that some patients do well, some do not do well. And we analyze the result, and Although it's 12 years on average, some went on for 17 years. The longest is the Malay teacher went on for 21 years with good quality of life. And for there, we pick up the important activities to involve in. And these are the activities. Now, during the health education, invariably, someone will ask me, Doctor, what is a good diet for my mother? So you see, our Singaporeans always talk about Okinawan diet or Mediterranean diet. And I tell my Singapore friends, there is nothing wrong with the Singapore diet. And can we look at it properly again? And as you see the picture, the top right-hand corner, the man at the corner there is Mr. Tan Fei Siong, and he's the boss at the restaurant called Malaysia Boleh. And I told him that, you see, people are not happy with so much of sauce and salt in the Penang KPL. He said, it's okay, we can arrange that. You can have less sauce or less oil, and it's something to satisfy the customer. So there's nothing really wrong. And the dish below is our favorite, the Teochew's favorite steamed pomfret, also the favorite of our donor, Professor Hong Hai, and it's something very healthy. And the top right-hand corner is Asam Pedas, which is Abdul Rashid's favorite, and it's also very healthy. And below is the wonton noodle, and some of you are watching from Batu Pahat, the very famous wonton noodle. Maybe you don't ask so much of noodles, but maybe more of the vegetables. And we've done a lot of research on diet and restaurant, and this study was done on tea by Professor Feng Lei. He's a world authority. He did a study with us on tea, and also a study on curry done by Professor Ng Zipin, and this study was published also in the American newspapers that curry is good for the brain because curry has a lot of curcumin, and turmeric is strong antioxidant. And our colleague, Professor Barry Halliwell and Irwin Chia, did a study on mushrooms and also fermented beans, which are also high on antioxidants. And also Professor Kim had done this big study on diet and mental health. And all these are important for our next program, our next, on Age 12 Everyday program. There are more than 10, 12 centers in Singapore. Our friends in Indonesia and Malaysia are also keen, and also as far as China, they are starting this program for prevention. And the program, although is moving on, will also improve on other areas, including family care and many other areas of interest, including caregivers. I want to stop now. I've got a couple of questions to ask the panel. Professor Mahindran, a question on what are the available medications to allay some of the symptoms.
Yeah, okay. So maybe very quickly, because time is catching on. I think if we look at the issues, patients with dementia, there are two groups that can be used, and those are the cholinesterase inhibitors. I'm sure many of you looking after your loved ones with dementia will be familiar with this medication. There are two types. There's donepezil or Aricept, and the other one is rivastigmine or Exelon. They are indicated for mild to moderate Alzheimer's disease, also used in Lewy body dementia and Parkinson's dementia. The Exelon is good for people who don't want to swallow, have difficulties with swallowing, because it comes in a patch form. And the Aricept, the donepezil, is also available as an oral dispersible preparation. So basically, it increases synaptic acetylcholine, which can enhance cholinergic transmission. Medication should be at least taken for 6 months, or maybe even 6 to 12 months before you can see any improvement. It doesn't alter disease progression, but does help in a certain way in terms of modest improvement or stabilization in the cognition. Side effects to some GIT side effects, gastrointestinal, nausea, maybe poor appetite, weight loss, sometimes diarrhea. There may be slowing of the heart rate, fainting episodes, sometimes may affect sleep, and there may be complaints of muscle cramps. The other one is the NMDA receptor antagonist, which is memantine. This one is more for those with moderate to severe Alzheimer's disease. Again, acts by regulating glutamate levels, and that, of course, helps the brain cells. So again, studies show that it has no benefit in mild Alzheimer's disease, but mainly for those in the moderate to severe group. Common side effects, dizziness, headache, constipation, and things like that. Sometimes also a combination can be used, but that would be the doctor's decision, that they use a donepezil together with the memantine. That's possible as well. So that's very quick review of the available medications for dementia now. But then there are also possible medications that can be used when there are behavioral problems, psychological symptoms that cannot be managed using psychological measures. So for sleep difficulties, when the mood is poor or the person is very agitated or irritable, so we can use antidepressants, small doses carefully. When hallucinations and delusions are severe, it does become a problem because we do know that antipsychotic use is associated with increased mortality. So therefore, it's very low doses, if at all, and only if really needed, but that's also possible. Mood stabilizers sometimes are used. You can use valproate, for example, if there's a lot of aggression, agitation, and things like that. Yeah. Generally, benzodiazepines are avoided because risk of falls it may worsen cognition. So that's just an overview. Yeah.
So now there are many other new medications. Once again, they don't cure the illness. They help to improve, to stabilize. And there's also a new medication for the tau proteins. And this is coming online now, and is available in some other countries. I want to ask Professor Tang Ling, how do you very quickly, how do you cope with the grief of losing someone with dementia? Or Abdul Rashid, are you there?
Yeah. So actually my father passed. Okay, so my father I actually expect him to live a long, many years, because I know that among my friends who are caring for their parents with dementia, it could be, as long as 10 years or more than that. So his death was like was quite abrupt, so we were actually quite shocked, because after we went to the doctor and got like a month's medication, and we thought, okay, not months, but quite a few months medication. So we were expecting him to, do well. But what happened was he had a lot of swallow difficulties. So the doctor was suggesting whether we want to have tube feeding for him. But I know that he likes to eat, and it's having that kind of quality of life, without with tube feeding would be very difficult for him. So we were still contemplating, and then suddenly he refused to eat. So he refused to eat for 2 days, and then the helper asked him, please, Akong, please eat. Then he say, what for? So I think he kind of sensed that, okay, he has enough of it. He has enough of living. But we thought, oh, then day 3 he started to eat again. He ate everything for dinner, so we were quite happy. But then when the helper after that helper cleaned him up, and then after that he just closed his eye, and that's it. He's gone. So we were very shocked, but in hindsight, I think he has a good death because he didn't suffer that much, and he decided I felt that he kind of take control of when he wanted to die. So it was sad, very sad for us, but at the same time, I think when people came for the wake and all that, they were like talking about, the last lap of life and how my father, has a good death. I think that was helping us, to cope.
Thank you. Thank you very much, Deng Ling. Abdul Rashid, how do the Malays cope with the grief?
Okay, sir. For me, especially when my mom passed away, so it's basically we are very sad about it. But to say sorry about it, because why? we do not know how to care for a dementia problem, because that time we do not know that she suffers from dementia. Only after I attended the talk from your teams, then only I realized. But to me, is basically that we just basically, just put it as something where it comes and goes.
Mhm. I think the acceptance of that is easier among
Yes,
the
sir.
Muslim group.
Yes, sir.
I know the time is already up. I've supposed to ask Professor Tan Ping Wee a question, but Ping Wee, we don't have time. But I know for all of us, we ask ourselves, who will take care of us when we grow old? I really don't know the answer. I hope that if I'm frail and bent over the age, Professor Tan Ping Wee will still give me a ring in the morning and ask me, Yi Hyok, are you still alive? I'd say, yes, I'm still alive. Would you want to join me to a cup of coffee? Of course, we go to a cup of coffee. And I think this friendship is very, very important. So I want to end by thanking all of the speakers, Rati Mahendran, Ling Ling, Rashid, Ping Wee, and the helpers here, Jia, Ian, Yi Tian, and all of you who are watching this program. There are so many questions that we cannot answer. We can be here for the next 5 hours and not finish it. But we'll try to reply your questions at a different time. So thank you very much and have a nice day, or what is left of a nice day. Thank you.
A big thank you to all our speakers for today. With that, we have come to the end of the Dementia Asia Living with Dementia webinar series. Once again, I would like to express our deepest gratitude for everyone for joining us and making today's session so meaningful. As you leave this webinar, you'll also be prompted to complete a survey. Your feedback is very valuable to us, so please take 5 minutes to share your thoughts. Thank you once again, and goodbye.